Hello, everyone, and thank you for joining us. My name is Jennifer Larson, and I am the training coordinator for the Office of Community Living. We are recording today's session with the intent to post that on our website. So please be cognizant of sharing any personal or protected health information, either in the chat or verbally. Our team is managing questions in the chat panel, so please type those in as you have them. A copy of today's slides are available on our website, and I have dropped a link in the chat. I'll add it again so that you can grab those. If you are listening by phone only and not in the video portion of the meeting, you can still participate by pressing *6 to mute and unmute your phone, or press *9 to raise and lower your hand to be added to the queue. And Zoom does provide closed captioning. If you turn on the live transcript button, or I think it may now be a CC button at the bottom of your screen, you can either turn that on or off. And with that, I will turn it over to Haley to start the presentation.
Good morning, everyone. Thank you so much, Jen, for getting us started. I want to welcome you to our quarterly American Rescue Plan Act update webinar. My name's Haley Gleason, and I am the Strategic Outcomes Division Director within the Office of Community Living, and I'll be helping facilitate today's discussion and presentation. We're so grateful to have you here. Next slide, please. As usual, we have a packed agenda. We want to provide a number of key updates for all of you on our progress to date in executing on our 63 ARPA initiatives. We also want to highlight a couple of grant opportunities that are currently available and make sure that you are well aware of those. And then we'll provide a couple of general office updates at the end. As you can see, we have a number of different subject matter experts from across the department that will be joining us to provide their expertise. So lots of content to go through today, but we will have different breaks throughout where we will welcome questions and discussion. So as Jen mentioned, you are welcome to put those into the chat at any time, and we do have staff members that will be responding in real time to those chat questions, but we'll also reserve some time for questions and discussion verbally. So if you would prefer to ask those questions live, we will give ample opportunity for that as well. Next slide. All right, so I'm going to kick us off by giving some general American Rescue Plan Act home and community-based services updates. Next slide. First, I wanted to give you all an update on where we are with our spending. As you all remember, this is $530 million that we have to spend approximately, and we have spread that out over a number of different years and across those 63 initiatives, as I mentioned before. So I want to highlight, if you can see here, it says fiscal year 2021-2022 budget. That's actually our expenditures through last July. So July 2022, we spent approximately $87 million towards these initiatives. And then looking forward, you can see our budgets for the remaining fiscal years. So we've got fiscal year 2022 through 2023. That is our largest budget. So that is this fiscal year we are currently in. It's almost $300 million that we anticipate spending in this year. And then you'll see it sort of ramps down from there. So fiscal year 23-24, you see we're about $122 million. And then fiscal year 24-25, which is when we'll be wrapping up all of these initiatives, we have about $3 million that we've budgeted. So that's really at the end and close out for all of our projects. Next slide, please. So this digs a little bit deeper into this current fiscal year. So fiscal year 22-23, so July 1st through June 30th. And you can see that the budget, again, is almost $300 million for this fiscal year. through October, so that's what's accounted for here, we had budgeted about 79 million that we anticipated spending. We're really close to that. We have actually spent about 73 million to date for this, or through the end of October for this fiscal year. So we are seeing that spending ramp up as we anticipated, and expect that it'll just continue, especially as we roll out more of our grant projects. We really think that that spending is going to increase significantly. Next slide, please. And this is just a quick reminder slide because our timeline has adjusted a bit. And so I just wanted to make sure that everyone was really clear on when the end date was. So if you remember, we originally had an end date for spending of March 2024. That's what CMS had required initially. But back in June, they had announced that they were extending the allowable time through March 2025. So they were giving us an extra year, and that's not just Colorado, but all states, an extra year in order to spend those funds. We really thought long and hard about that offer to have the extra time. It's important to note that with that extra time, it also means that we had to maintain the maintenance of effort, the MOE requirements. And so in making that consideration, we decided that we would leverage the extension, but only through December of 2024. So the important date to remember now is that our end date for ARPA HCBS spending is now December of 2024. And you can see that here we've listed that 27 of our 63 projects will be extending to that December 2024 timeline. We really went project by project and determined whether there was a need for that extension versus taking an approach where just a blanket approach of applying it to all projects. We feel really strongly that it's important to get these projects accomplished and to get the money pushed out as quickly as possible. So we looked at each of those projects and considered the impact and whether those projects would have a greater impact or be more likely to succeed and spend their funds if we were able to give them that longer time frame. And so at this point, we have approved 27 of those 63 projects to have a little more time in order to wrap up. Next slide, please. All right, so those are just some high-level updates on where we are with ARPA HCBS. I want to pause and see if there are any questions about anything that I have reviewed before we move into some of our key project updates. All right, I'm not seeing anything in the chat. I just want to make sure, let me look and see if there are any hands raised. I'm not seeing anything yet, so great. I will keep things moving along. If you can go to the next slide, Jen. Great, so now we are going to move to our key project highlights, and I'd like to introduce Emily Holcomb. She is our Behavioral Health Crisis Response Policy Advisor within the Office of Behavioral Health Initiatives and Coverage. So Emily, I'll hand it over to you, and Jen, you can move right on to the next slide.
Thanks, Haley. I'm happy to be here. Yeah, as Haley said, I'm Emily Holcomb at HCPUF. I use Emily and they, and I am the Mobile Crisis Policy Advisor. So I am working on ARPA 2.02, which is focusing on the expansion of crisis services across Colorado. So we are adding to the crisis continuum by launching a new mobile crisis response Medicaid benefit, which will be available to all Coloradans regardless of their insurance status. So that means we are adding a Medicaid benefit, but all of these services I'm going to talk about will be available for all Coloradans, whether they are a Medicaid recipient or not, or if they are unenrolled in any insurance. The department and the Behavioral Health Administration are collaborating to design this benefit, So we are taking advantage of the new federal option under the American Rescue Plan Act 2021, which is offering states enhanced federal Medicaid funding for up to 3 years for community-based mobile crisis services, which meet federal requirements. So building off of ARPA requirements, as well as national and state best practices from SAMHSA and other states, we also engaged in extensive stakeholder engagement to build the draft benefit, which we are working to finalize in the next month. And I will paste information about that so you can view the draft benefit and have opportunities to give some feedback if you have any before we finalize. The goals of this service are to improve service quality, so making sure everyone is getting the same standard of care, to reduce unnecessary service utilization, and that includes hospitalization, inpatient and outpatient care, as well as unnecessary arrests related to their crisis. So working to keep folks in community and resolving crises where they are at. We are working to enhance client connections to community-based services. So again, the goal is to keep people in community and be connected where they are at to whatever services are available there, so they can have ongoing supports to prevent future crises. We are working to strengthen network capacity, especially for target populations. So that is focusing significantly on people with intellectual developmental disabilities, traumatic brain injuries, and some other different categories, as well as folks who may be deaf, hard of hearing, deaf-blind, and then there are other training components that will focus on several other target populations. We're also seeking to increase awareness of these services across Colorado, and part of that is with the goal of integrating within the crisis continuum, and that is in significant partnership with the BHA related to their engagement and marketing efforts on 988 and other crisis services. We can move on. So this service is available 24/7, 365, wherever you are in the state. It occurs where the client is at in the community to offer relief and stabilization. Calls are received through a variety of lines, including the statewide hotline, 911, 988, and teams are dispatched if it's an appropriate service, and providers work with the client to resolve their crisis episode. If mobile crisis response is not appropriate, then another provider would show up based on what type of crisis is happening. It is delivered by a multidisciplinary team with specialized crisis training and expertise set by federal requirements. So whoever clients are, they would receive services from people who include bachelor's and master's level clinicians. It would include peer counselors, people who've been through these experiences, and other people who meet the crisis training standards. Providers must coordinate follow-up services for the client. Say they want to keep folks in community and connected to services. And it's not a replacement for ongoing mental health and substance use disorder treatment services. So this is an option to take care of emergent needs, but we really want to support clients and members to continue accessing health, mental health, and substance use disorder services. It also doesn't replace any existing crisis services. So if you've been working with anyone else or know about co-response programs and the work that law enforcement or EMTs may be providing, this doesn't replace it, and those will continue, but it is another option, and it's just another option to provide a mostly non-emergency and non-medical response. We can move on. Thank you. So this service definition does outline the key components that comprise the Medicaid benefit and are intended for use by these teams and also apply to anyone else who are providing crisis services through coordination and providing this standard across the state. So the main components are to engage with community partners. These mobile crisis teams need to be connected to whoever is in the community. So this is probably libraries, schools, anywhere that works with the public and a crisis may happen or is a key social support. So crisis services need to be aware in those communities and the information available to all of those folks who provide social supports. Dispatch integration means that we are working to connect dispatch lines to the mobile crisis teams in a very sustainable as well as a way that is very smooth, which means we will be working with 988, 911, other hotlines to ensure that services are getting dispatched appropriately, meaning it's the right type of service, and it happens within a timely response amount of time. Mobile crisis response activities include the face-to-face risk assessment, which is going to be a shorter assessment, which is complemented by whatever happens in dispatch, which is a longer assessment. But once a crisis provider gets to the scene, it's a shorter assessment, which should make the experience better for clients so that the response is actually focused on the brief intervention, stabilization activities, and de-escalation of the crisis. And then they would move on to crisis and safety planning and moving into follow-up activities immediately after the crisis, which can occur face-to-face or via telephone and is intended to coordinate with referrals to health, social, and other services and supports. Mobile crisis teams should, again, really maintain relationships with community partners. So making sure they're aware of this service and they are updating their practices based on what the community needs. Staffing requirements are being expanded through the new definition of a crisis professional. So teams will include a lot of multidisciplinary folks, and they may have a varying level of educational background, so they don't have to be a master's level clinician, but they can be a variety of folks, which will support more diversity in the actual teams, hopefully allowing for a little bit of more positive relationships with clients. Team members, they are required to show up in a paired response. So one person is at minimum required to be on the scene. And if the distance to the crisis means that only one person can respond, then the other partner has to respond via telehealth. So it does still occur as a paired response. And then we're updating the training requirements so that we ensure people have quality responses, which includes cultural competency, relationships to folks with different disabilities, other crisis-related and specific to crisis trainings. Current crisis providers have a variety of trainings, and so we want to work to standardize these requirements through the Behavioral Health Administration Learning Management System, which will also translate into a crisis certification for that organization. Again, it's 24/7, 365 availability across the state. In urban areas, it requires a 1-hour response and 2-hour response in rural and frontier areas. And it has to occur in communities, so it can't occur where other crisis services are available. You can, again, use telehealth if for some reason 2 people in person is unable to occur, but the second person does have to respond via telehealth. And if needed, the team can coordinate or provide secure transportation for the person, and then it will become a different type of response. So that is a main overview of what's in the service. We will share the benefit description with you all so you can read more in depth about the details. Next slide. So here's what we've been doing. Since January, we've launched an assessment of the crisis landscape in Colorado, including interviews and developing a work group to inform benefit design. And we took the draft benefit out into the community through virtual and in-person meetings, which concluded this month. And now we are moving into technical assistance for people who will implement this benefit. And we're offering, again, technical assistance, so figuring out what people's questions are and helping provide solutions. And then the BHA, Behavioral Health Administration, is distributing funding to support ASOs and providers to meet the new requirements. And this will be done through a needs assessment of what they are capable of doing and what resources they need. And then we're planning on launching in July 2023. Next slide. So our next steps are to launch these technical assistance meetings. I'm happy to share the information with you. It is listed on the website I linked to in the chat. So you can see the schedule. They occur on Thursdays. There's one every week, and they're for different populations. But you can reach out to me to get more info and visit us at the member experience, provider needs, or general meeting. And again, on that link, you can see the draft benefit, and there is a forum if you have feedback you're welcome to submit to, and then a needs assessment will be coming. Happy to answer any questions and also provide follow-up answers. I'm not sure how much time I have, though.
Thank you so much, Emily. It does look like there were a couple of questions in the chat, but Amanda has responded to those. So I think we are all set at the moment, although there was one question from Tara that I wanted to read, and I think we've got Colin Laughlin on to respond. Sorry, Tara, let me just get to that question. Your question was, why did you choose ARPA funds to do grants other than rate increases, which has proven to be what really is needs to be done? So Colin, I'll hand it over to you to give a response.
Sure, thanks, Haley. So Tara, I appreciate the question. Just first and foremost, this is the webinar for the disability, older, aging adult community and the advocacy groups that we work with. We have a provider-specific webinar this afternoon. That said, we promise to use this money to determine the best solutions to longstanding problems, really search out innovation. However, with that said, to date, we have invested nearly $275 million in both rate increases and efforts around supporting the direct care workforce. And with this entire conversation around the American Rescue Plan Act bucket of funding, one of the biggest questions that we got from people is, how are you going to create sustainability? We didn't want to create a cliff in which people got rate increases for a year or two, were able to get stabilized, and all of a sudden that was taken away because the ARPA funding ran out. And so really what we did over the last year was work very closely with our legislative partners to ensure that that funding had sustainability around that. And to the credit of the legislature and the work that was done here, listening to the advocacy communities, the provider communities, we were able to make that historical investment into the direct care workforce and into our provider agencies here in Colorado. So while that, I understand that is oftentimes, where people really look is the investment in those direct dollars to rates. We also wanted to look at innovative projects. So we think we got the best of both worlds. And if you haven't, you can also look at our November 1st budget. There's an additional increase there that we're targeting for many of our providers. So it is top of mind for us, but it is also that, we have put a pretty significant investment towards the provider and the workforce here in Colorado.
Right now, we're working on updating information about rates, provider types, all of that. So whoever our providers will get more information as we finalize things around this and state plan amendments. More info to come. We are working in partnership with different co-response programs. This is a different approach, however. So we want folks like Denver STAR program to know about this resource and hopefully refer to us as needed if we don't need the same response. What this mostly also offers, as Whitney asked about, is this in place now or beginning at a later date, is the new Medicaid will allow providers to actually bill for this specific service rather than bill the state general fund or billing for something else or being unable to bill if it's a law enforcement response. So these services are available, but this new benefit allows for providers to bill, and hopefully this will be a motivation to actually access and bill the service. So happy to, again, answer questions. You can email me, and hope that this excites you about crisis services in Colorado as an additional option to prevent hospitalization, medicalization, and arrests of folks. So I'll pass it on to Kim Cortez, Competitive and Supported Employee Unit Supervisor of the Office of Community Living.
All right. Hi, everyone. My name is Kim Cortez, and as Emily said, I'm the supervisor for the employment team here at HICPUF. Every year in October, we celebrate National Disability Employment Awareness Month. And since there wasn't a webinar scheduled last month, I have the pleasure of talking to you about it today. And I have to say, I'm very grateful to get a few minutes to highlight the important role that awareness plays in creating employment opportunities for people with disabilities. Whenever I have a chance to talk about employment, I like to start with the data. So nationally, for people without any type of disability, workforce participation averages 76%. And by participation, what I mean is people over the age of 16 who are either actively working or looking for work. For people with any type of disability, that rate goes down by more than half. And for people with a cognitive disability, the numbers are even lower. At HICPUF, we're working to change that in Colorado. We're an employment first state, which means we support full integration and community employment for all Coloradans. We have a lot of projects that we're working on towards that vision, including eliminating sub-minimum wage, developing some new benefits to reduce barriers to employment, and expanding the buy-in program to include the developmental disabilities waiver. We're also running a pilot program that you'll hear more about in a minute from Colin. While there's a lot of systemic barriers to employment for folks with disabilities, and we're working to change those, Disability Employment Awareness Month is important because ultimately, in my opinion anyway, the most significant barrier to employment is a lack of awareness. It shows up in a lot of different ways. The thing that always comes to mind for me first is employers who maybe aren't aware of the skills folks have to contribute, or maybe have biases or assumptions about people with disabilities. But it's also more than that. There's not enough awareness in our community about what supports are available related to employment. And there's still a pretty widespread belief among some folks that you can't work and keep your benefits, or that if you do work, it needs to be minimal. And we even hear from some of our members that they aren't aware of what kinds of jobs are out there because they haven't been given the opportunity to fully explore what their career interests might be or what options might be available to them. So luckily, raising awareness is something everyone can help with. So this is my little pitch to all of you. I hope you'll join us in spreading the word next October. But you can help create opportunities for Coloradans with disabilities by keeping employment front and center all year round. Talk about it as much as you can, talk about the people you know and what you know they can do and want to do, and help us sort of shift minds all over the state. With that, I'll pass it back to Colin to share more about our supported employment pilot. Thanks, everyone.
Thank you, Kim. Super excited to have Kim on board in all the work that's going around supported employment right now. It's a very exciting time, and I think Colorado is a national leader in many regards, and so excited to start getting these things really kicked off. So if we could go to the next slide, please, Jen. To what Kim had spoken about a little bit, we have a supported employment pilot here in Colorado, and it's really just an innovative project that while it's focused in Colorado, it's nationally innovative in what it's trying to do. And we have people sort of across the country who are paying attention to how this operationalizes. So typically like a job coaching, most of our benefits, it's a fee-for-service model. And that works pretty basically. You provide the service, you get paid that particular fee. What we're trying to do here is actually test incentive-based payments that are tied to outcomes for long-term employment rather than just basic hours of service. Sometimes that can create an inverse incentive. And so with the goal there of trying to fade the job coaching and actually fade those supports out while people are working, creating better employment outcomes for members, we'll be able to really, over time, look at how those people are engaging with the work that they're doing and how they're remaining in those particular jobs. So it's really there in the process to promote independence, promote autonomy, and then get people successful on the job, in which that job coaching, they're sort of working themselves out of a position with those individuals so they can be truly integrated into that place of work. So a little bit more about supported employment. Go to the next slide, please, Jen. We have 5 providers in the pilot. They're, rather than being paid for each unit of job coaching, again, that fee-for-service model, they're paid based on each hour a participant is working, actually meaningfully working. So this incentivizes those providers to actually get out there, find that job, have people work in that position. So really exciting stuff, working on getting people connected, getting people to increase their hours worked, utilizing the best possible job match for those individuals, and then taking that data at the end of the day and trying to determine whether or not we can continue to create this incentive-based pilots. And the initial results are very positive, and we're looking forward to potentially being able to expand this program into the future. So more to come on this, but exciting work here, exciting overall conversations we're having in the state of Colorado. A lot of movement, sub-minimum wage bill from several years ago, just a lot of really cool stuff. And to Kim's pitch and ask, we would really love more people to get engaged. Obviously, this is the advocacy and disability webinar, but if you have anyone in your life or you have an interest, please let us know, as we'd love to get more involved with certain communities across the state of Colorado. With that, I'm going to turn it over to Mark, who's going to talk a little bit about our ACC Phase 3.
Hello, everyone. My name is Mark Corello. I am the Planning and Implementation Section Manager for the Accountable Care Collaborative Division. Sorry, I probably should have had one slide on basics of the Accountable Care Collaborative. Just to make sure we are all on the same page, when I reference the Accountable Care Collaborative, I'm primarily talking about our regional accountable entities, or our RAEs. Those are the organizations that are responsible for promoting members' physical and behavioral health. And they do that by creating a network of primary care medical providers, or medical homes, for physical health care for members. And then they also administer the department's capitated behavioral health benefit. So that means that they are paying claims and doing utilization management and developing that network of providers on the behavioral health side. So that is the program. Our current contracts with the existing regional accountability entities started in 2018, and they will end on June 30th of 2025. So we are starting the work to design and begin the process for procuring new vendors that will start on July 1, 2025. And so here's a timeline of how we're going to get there. We are literally just starting all of our external stakeholder work this week. And so we are going to be engaging. We've contracted with the Colorado Health Institute to help us with external stakeholder work. And we'll be talking with people in a variety of venues over the next few months. That will be done in collaboration with our internal work groups that are focused on a variety of topics right now and exploring what are the best policies, programs that they can work on with our external stakeholders. That will result in, starting about March, we will release a series of concept briefs. So they will be very topic specific on what are the new policies, programs, changes that the department is planning to make as part of the Accountable Care Collaborative. We will be continuing stakeholder work throughout this, but that will, once we've released those briefs, more stakeholder engagement that will help inform a draft request for proposal. And that is a draft of what we will send out that will be the contract basically for potential vendors. We will post that for public comment and host a number of meetings around that. We had a form on our website in the past to capture the public's comments. And so we will take all that information back and just through continuing ongoing conversations, finalize that request for proposal and post that in April of 2024. And then we will review those proposals and award those vendors around September of 2024. That should allow about 9 months of transition time between existing vendors and the new vendors that will start on July 1, 2025. Next slide, please. So today I just really want to give you a high-level overview of where we are, or what the department is thinking. So the goals that we have for phase 3 of the Accountable Care Collaborative are pretty much aligned with the department's mission. So we want to improve quality care for our members. We want to focus on closing health disparities and promoting health equity. We want to improve access throughout the system. It also is a high priority for us to improve that member and provider service experience. And then as always, we just need to be conscious of costs and how do we manage costs effectively so that in the case of recessions, things like that, we're able to protect member coverage and benefits and provider reimbursements so that we are using the taxpayer dollars as cost effectively as we can. And so how we're going to achieve this, the next slide, please, is we've identified 8 areas of priority. I will put in the website a link to the ACC web page, which has a fact sheet that provides a little bit more detail on this, but just wanted to give you a high-level overview. So we are really focused on how do we improve member communication and support and ensure that members can more easily access the information they need, the benefits they need, and without having to go through 5 or 6 different agencies or phone numbers to call to get those services. So how can we continue to streamline that and better support members? We want to increase accountability for equity and quality throughout the system. That is both at the regional accountable level as well as our provider level. We also know that it's really important to be addressing the health-related social needs. And the RAIs currently do this, but what more can we do around how do we improve referrals from members to community organizations for those non-medical supports and services that are vital to people's well-being? The department is also has begun implementing a number of alternative payment methodologies, such as those within primary care and maternity health. So we want to continue to implement those, evolve those methodologies, and identify where there are new opportunities to do that. With the implementation of the Behavioral Health Administration, there's a change in the safety net behavioral health providers. So how can we develop alternative payment methodologies that really focus on delivering value for those new safety net providers? So looking at all of those new opportunities. Care coordination is critical to the Accountable Care Collaborative. We know it's critical to our members' success. So really, how do we continue to work at better defining and setting expectations, particularly for unique populations, such as those individuals with disabilities, to ensure that they're getting the support and, that they need to best organize all of their services. One thing I should say is, as we think about ACC Phase 3, we are trying to figure out how do we leverage all the advances that are happening through these ARPA funding projects and ensure that we can sustain them as part of the overall Medicaid program. And so care coordination is one of those projects that you will hear about right after me, that we have a specific project that is looking at the case management agency definition of case management services, the regional accountable entities definitions of care coordination, and how do we better align those systems and create better clarification about who's responsible for what, and how to ensure that there is a transfer of essential information so that all of the members' health and care needs are being met. So that is a high priority for this work. We also know that children and youth have different healthcare needs, and so we really want to improve access and outcomes for children and youth, particularly those that that have complex medical health needs, also those involved in the child welfare system. So, what are some specific innovations we can implement to try and improve their care, as well as improve the experience for their caregivers and their providers? You hear a lot about behavioral health transformation with the implementation of the Behavioral Health Administration. We want to support that work and partner with them closely and identify further gaps that are in the behavioral system and find ways to continue to improve that continuum of community-based services of care so that we can keep members out of inpatient and residential settings as much as possible and serve them as effectively as possible in the community. And then last but not least, how do we leverage new technology to really support both members and providers and support continue to move towards real-time data sharing so that our care coordinators, our case management agencies, our providers have the necessary information in close to real time so that they can intervene effectively with members and provide that support. So those are really our high-level priorities. As I said, there was a fact sheet on the website that I put in the chat that just provide a little bit more information. But over the next couple of months, we're really diving into this with the stakeholders, and we'll be hosting public meetings. We'll have a survey on this. So if you are interested, really go onto that ACC Phase 3 webpage and sign up for the newsletter, and you'll get informed. But we'll be using that webpage to really announce all of the new presentations and opportunities for people to get involved. So thank you very much. And I guess I will pass it over to Amanda now.
Great, thanks, Mark. Good morning, everyone. I hope you're all staying warm and enjoying the beautiful white flakes that are falling out of the sky. I know I'm very excited, especially with it being our first real snowstorm. So, but I think, many of you know me as Case Management Redesign. I oversee all the case management programs and services within the Office of Community Living. And I think, for me, it's really a great opportunity to coordinate and collaborate closely with Mark and his team on this work so that we're really leveraging both of these programs and projects to really make sure that we are truly simplifying for members navigating and accessing, whether it's long-term services and supports, but also, as Mark mentioned, those medical and behavioral health. We know that there are sometimes challenges and complications, and really have to make sure that we're collaborating and working closely so we don't make it more complicated or challenging to get the basic services needed. And so Mark and I have worked really closely together and our teams to really put together a plan to how do we make sure that we're clearly defining roles and responsibilities for each of the respective entities, and that there is really that true coordination at the local level and in the community and kind of behind the scenes too, so that members don't have to have 6 or 7 or 3 or 4 case managers or care coordinators kind of making it sometimes complicated. And so how do we make sure that everyone knows who's doing what, when, and where, and how? We also know that there's gaps, though, and to be able to achieve that, we really have to identify and address each and every one of those. But we need to be able to do that, also get input and really understand from members and providers, where there's clarity or lack of clarity around those roles and responsibilities, so that we're not duplicating services or efforts. Because at the end of the day, our goal is to really improve member experience and have a positive experience working, whether it's the case management agencies or the RAIs, or in oftentimes cases where individuals are working with both entities, it is a good outcome. For Case Management Redesign, a huge role and goal of ours is to simplify our system, but improve quality outcomes. And so there's a lot of correlation to both of these projects. In order to do this, on the next slide, we actually have a dedicated project coordinator that was just hired. Her name is Lauren Landers-Tavers, and she comes to us with extraordinary experience and knowledge of different programs and different systems, and really trying to blend together all of the different work that we're doing. She reports to Mark, and we'll be working closely with my team. Many of you know Kidron, and her team to really begin to do stakeholder engagement after the new year, where we can really flesh out and put together our plan for how we'll address it both through the raise and case management contracts going forward. So thank you. If we can go to the next slide, a couple of other exciting case management projects that we're working on is, we've been working really closely on case management redesign and really understanding that if we're to achieve our goals, we have to make sure that we are paying case managers in a way that achieves our goals. And so we hired Myers and Stoffers to assist us with a couple things. The first thing is really looking at how case managers are spending their time and understanding how that is done each day for the different activities and requirements that they have from the department, and then also what's not included in that. So a lot of work went into that comprehensive rate study and analysis of the work that's currently being done. From there, Myers and Stoffers is has made 6 recommendations to the department for our future payment methodology, and areas that we need to have additional consideration and additional work to really understand the implications. And these 6 areas are, rural and urban travel time. In the rural areas, it's a distance, but in the urban areas, it oftentimes is a time, because of the amount of congestion on the roads that sometimes can be very similar. And so we currently have a rural travel payment add-on, but we need to dig in and look more at the urban. One of the recommendations was also a caseload size limitation. And so really having standards around caseloads. And so we are looking at in our future state of case management to have a standard set at 1 to 65 for our caseloads, so that we can really make sure that case managers have the time that they need to work with members and actually provide a high quality service. So we're very excited about this work ahead of us. Another area of recommendations was training and really making sure, and we've heard this from members and families through our stakeholder engagement on case management redesign, how important consistency is, and solid training for case managers. So regardless of where you live, you're getting similar information. And that it's up to date, and that the trainings are really more interactive and have a way to really support case managers in all of the various different adult learning styles. And so we are working very hard on putting together a training platform with which is called a learning management system that will then house all of the required trainings and optional trainings. And so we can track and assign and really have a better insight into the training needs of case managers. One of the other areas was really making sure that we are reviewing the rates on a reoccurring and regular basis. And that the next one is, moving away from population-specific case management rates and really having more of a holistic case management rate that is blended depending on the needs of the organization and the individuals that they serve. And then the last one is really looking at some innovation around quality measures and payment structures in the future for the department to take into consideration. So we are in the process of approving that their report on the recommendations, and we will be posting that to our website soon. In addition to the work around the rates, the rate study, we also have a budget ask to increase our rates. Over the last 5 years, we've increased our funding for case management agencies by 25% through various targeted increases. And this includes a total of $15 million in permanent case management funding and $4 million in temporary initiatives. But we also know that to really get that caseload size to the standards that we are hoping for, we need to do an increased rate to the base. And so we are requesting to infuse 7.8 million, which is just under 8% of the total funding into the system so that we can continue to really have a huge investment in case management to achieve our goals. So moving on from the work that we're doing on with rates, we're also really focusing on recruitment and retention of our case managers. They're such a vital part of our programs, and we really need them to be retain them through all of the various changes that we're doing. So we're working on both short-term and long-term strategies, and one of them really includes getting satisfaction and information directly from case managers so that that can inform future strategies for how we maybe work on recruitment and retention. So in addition to those satisfaction surveys that is currently out right now, and we're having incredible response rates, we are also going to do retention payments for case managers starting at the end of this calendar year, first of next year. So with that, Haley, I'll turn it over to you for questions and answers.
Great. Thank you so much, Amanda. Well, that was a lot of information on some really incredible projects, a lot of really exciting things happening across the department. I want to pause and see if we have any questions from participants today. I have not seen any come through in the chat, but want to give you an opportunity. If you do have anything, you can either write those in the chat now. You are welcome to raise your hand and we can call on you. If you're on the phone, you can hit *6 to unmute yourself, and you can also ask a question live. All right, hearing none, I'm going to keep us moving. Next slide, please. All right, so I am going to now move us into talking about our grant opportunities. Obviously, this is really exciting for a number of our providers, our community-based organizations, our members, and our direct care workers who can apply for these grants, which cover really a wide variety of different opportunities. So we are going to highlight a couple today. Next slide, please. First, I just wanted to give you a high-level update of where we are with our grant rollout. So to date, we have had 6 grant initiatives that have opened their request for application. We call that the RFA. So they've opened their RFA process and since closed. So that means they've made that application live and have since closed it and have begun reviewing the applicants. Awardees have been selected and contracting is in place for 29 grantees currently. So we're really excited to see that these funds will start to roll out and get into the hands of our providers and those community organizations. 2 grants are still reviewing applications, so we expect that those awardees will be selected soon. An additional 2 requests for applications are currently open right now, and those are the 2 that we're going to talk a little bit more about in the event that those might be a good fit for you or your organization. Across all of these 8, so the 6 that have opened and closed and the 2 currently open, there's a total of $65.5 million in grant funds to be distributed out to the community. So we are just so thrilled to get that money out into the community. Finally, there are 8 requests for applications that will be opening in the coming months. So if you have not seen one that's quite the right fit yet, don't worry. There will still be more to come, and we really recommend that you keep an eye on our grant opportunity webpage. That's where we post, and that's where you'll find all of the RFAs, as well as in our newsletter. We'll always update you in the monthly newsletter about new RFAs that are open. Next slide, please. And to talk about, before I do that, I wanted to mention our grant financial vendor, PCG. So for those of you that are interested in applying for one of our grants, we are leveraging a grant financial vendor. So what is their role? They will actually be creating the grant agreement documentation, so the contract, and then they'll be managing the agreement and making payments to the grantees. Because we have so many grants going out through our ARPA initiatives, this ensures that there's consistency and standardization across all of those. So what would that mean for you if you're a grantee? In most cases, you would be working with PCG to execute that grant agreement and then to submit your invoices and any other reporting requirements. So they would be your primary contact, though the subject matter experts within the department would also be very much engaged. All right, next slide, please. Now I will hand it over to Amanda Smith with the Office of eHealth Innovation to talk about one of our grants that is currently open, our Dollars to Digitize. Thanks, Amanda.
Thanks, Haley. Appreciate that. As mentioned, I'm Amanda Smith, and I'm the project lead for the ARPA 606 Dollars to Digitize grant program. Really excited to tell you all about it. So it's $18 million in available funding to Health First Colorado enrolled HCBS and behavioral health providers. And the intention for this grant is for provider digital transformation and EHR upgrades. This would include things like connection to a telehealth software service or to a connection to the HIEs, or things like technical assistance that we know a lot of our providers will need additional help implementing their digital transformation projects. So there's a total investment of $18 million, and each organization is eligible for up to $500,000. Next slide, please. Okay, so I want to expand a little bit on the eligibility criteria. So first, as mentioned, home and community-based service providers who are serving 2 or more Health First Colorado members within the past 12 months. For behavioral health providers, they do not need to be providing HCBS services. They just need to be a Health First Colorado enrolled behavioral health provider serving 30 or more members within the past 12 months. So how do providers apply for this exciting grant opportunity? Well, it is delivered in 2 parts. The first part is a 20-minute initial eligibility screener, which is called the intent to apply form. You'll see that there's a link to it here in the slides, but I want you to know that the intent to apply form has been open since August 3rd. However, it actually closes tomorrow, November 18th, end of day. So we're hopeful that as many providers who are eligible and interested are able to apply before the end of the day tomorrow. Again, it's only 20 minutes to determine if they're eligible or not. If they are eligible, they will receive an email from us with a link to the full application, which could take upwards of 2 hours or so because it does include a technical readiness assessment, among other questions. It could take a while. So we wanted to make sure that providers had an opportunity to first see if they were eligible before spending all that time and resources on applying to the full grant opportunity. Now, that full grant application is due Friday, January 6th at 5 p.m. And there's a link here on the slide also to the ARPA 606 website, which has all this information, all the links, as well as some helpful materials and resources for providers. Next slide. And you'll see in the chat too that the website link is available as well. So let's talk about the timeline. The ARPA 606 Dollars to Digitize grant program is actually going to be delivered in 2 RFA phases. So round 1, request for applications, started this fall. As mentioned, it kicks off with the intent to apply form and then is followed by the full application, which closes on January 6th. And that again is for providers who are approved with the intent to apply form. And if you look at the timeline here in the red section, you'll see that between February and April is when we believe we will have determination of awards, and providers will receive an announcement at that point in time. After that, the round 2 will kick off with the intent to apply form, opening up to and prioritizing the case management agencies and those who will be transitioning to the redesign or continuing on with their direct services. They will be eligible in the summertime roughly to apply for Dollars to Digitize with the intent to apply form. And we'll also see that the round 2 application and awarding period will be sometime between July, August, and then we expect awards to go out no later than September, November timeframe. And with that, I will hand it over to Colin Laughlin to talk about our training grant opportunities.
Thank you, Amanda. And I see there are a couple questions. We actually have a section here at the end for questions, so we'll get to that momentarily. If we could go to the next slide, please, Jen. So I wanted to talk a little bit about the training fund. It's a really exciting initiative, and frankly, I think really gets to the broader conversation that we're trying to have around the direct care workforce. And so with this training fund, what we're looking to do is focus in on provider organizations or individuals even. We have 2 different funds, which I'll talk about here shortly, that would promote greater retention, would promote training, getting those skill levels up, focusing on different types of disabilities, things of that nature. An exciting opportunity to ensure that our workforce is able to grow and really get that additional training that oftentimes is not available because of how tight some of those funds are for our providers. So giving them that opportunity there. And the first one, if we go to the next slide, please, is specific to our providers. And both the provider and individual grants have a total of $9.5 million, which is a significant amount, but we certainly want to spread the message pretty far and wide around this one. And so what we're looking to award is up to $100,000 for our providers to, again, look at that workforce, figure out if they can enhance sort of the background training, that baseline training, but also go into new areas and see if we can get some innovative models that really ensure people are able to grow and meet the needs of that disabled population. So with the provider grants, this is actually had been posted already. The first awards will be announced on the 15th of December. And then after that, there is likely to be sort of a rolling opportunity there with the provider grants. Could go to the next slide, please. Thank you, Jen. The individual grant is up to $500 for individuals who would like to pursue some additional training on their own, maybe not associated with a provider if they want to say get some expertise on working with a certain disability type or get some additional training on a certain service. It's a great opportunity to get that work and potentially even get that credential to really show potential employers out there or your current employer that there's an interest in getting that training and sort of taking that next step within your within the work that you're doing there. And so that will be something that moves forward here shortly. The individual grants will be accepted soon. I think the goal is to start doing some awards here the early part of next calendar year. So keep an eye out for that. And I think someone will post that in the chat if they have not already. In terms of as a provider individual, please make sure you're taking these steps to apply for the grant. If we could go to the next slide, please, Jen. As a provider, check the Secretary of State website to ensure you are registered as an organization or a business and are in good standing. Please keep an eye out on our grant opportunity webpage. Please look at our Project Pulse newsletter. The monthly newsletter that goes out each month has updates around all things American Rescue Plan Act, as well as specific deep dives into some of the work that we're doing. And then please remember these funds are to supplement your work, not supplant existing work. And so, if you have a training program, being able to expand that program or look into new initiatives is really what this is intended for. So great opportunity, really would encourage you, again, as members, as family members, others who maybe work with providers, to let them know about this. We're really trying to cast a very wide net across the state, look at different models of training, even look at how that geographically may vary. So again, would strongly encourage you to send this out to your networks. And with that, I will kick it over to Haley for some Q&A.
Thanks, Colin and Amanda. I'd actually like to pull Amanda Smith back up. Amanda, I saw that you responded in the chat, but I think it'd be great if we shared that with everybody. So Sarah had a question. She asked, eligible applicants who have already filled out the intent to apply, have they been already informed if they did qualify?
Yes, absolutely. We are pre-qualifying conditionally applicants on a routine basis, and we're also sending out email denial letters if we're missing required documents, or maybe our validation of eligibility was off a little bit. So our technical assistance support team for the application is just on it. And those who have been applied, the answer is yes, or have applied, the answer is yes, they have been notified by us by email of the determination. Great question.
Great. Thanks, Amanda. And one more from Jackie. She said, with the grant money, is this money you would need to pay back?
The answer is no. This is a grant. This is a huge investment in the HCBS and behavioral health provider community to enhance their technology and digital transformation. So it does not need to be paid back.
Great. Thank you so much, Amanda. I will pause and see if there are any other questions. Feel free to write those in the chat or raise your hand and you can ask those now. All right, and I see that Jen has put links to both the Grant Opportunities webpage and to our ARPA newsletter. So again, just encourage you to take a look at that. Next slide, please. All right, I'm going to call Colin back again to provide a couple of other office updates.
Sure, thanks, Haley. Wanted to give folks an update on some other happenings, not necessarily related directly to the American Rescue Plan Act. Have a couple updates and some information for you all around the public health emergency, or the PHE. We did not hear in early November that they were going to be ending the public health emergency, so that means it is extended again. It will run through the next part of early calendar year. The next 60-day notice is due on the 10th of February, which means, again, they have to give us that 2 months notice in order for them to end the PHE. That was the agreement that they had made. And so right now, the expected end date is April 11th of 2023. Any updates that we receive around that, we'll be sure to share that with our group. To that end, if we could go to the next slide. There was some conversations around the PHE and sort of COVID et al., if you will, this week. So actually on Tuesday, the Senate voted to end the emergency declaration. That is not the public health emergency. There's a difference there, and we received some questions about this, so wanted to provide some clarity. The PHE, as we understand it, the public health emergency, can only be ended by the Department of Health and Human Services. And so that PHE, in which we received the enhanced funding, a lot of the flexibilities that we have under certain waiver agreements with the feds, all of that will expect it to be continued. The emergency declaration, however, is tied to things like the student loan payment freeze that's occurred since March of 2020, or April of 2020 rather, certain additional domestic things like ports of entry and customs deadlines that have been affected by that. Those are all part of the emergency declaration, not part of the public health emergency. And again, currently slated to end on 4/11 of 23, but if that changes, we will let you know. If we could go to the next slide. This is really fantastic information because the situation is very fluid and there is a lot happening, even confusing things like the Senate vote this week. We'd ask you to bookmark the Public Health Emergency Planning website there. Make sure in particular, if you are an individual in services, that you have really a keen eye as to what that looks like, making sure all your information is updated. So there'll be webinars that are actually beginning this month, talking a little bit about what to expect around that unwind, how certain things in eligibility will work. So please bookmark that website and keep it refreshed from time to time as we move into next calendar year. Actually have a specific example. I think if we can go to the next slide, please, Jen. Yep, thank you. So if you could actually go to this and look at the work that we have, the Stay Up to Date section there on the side. will allow you to really understand what the PHE looks like and what's happening within that. Again, this would be another area, this supportive employment, a lot of the grants. If you could share with your networks, it really is critical to get this information out. We don't want anyone to be caught blindsided with any changes to the public health emergency. So I'd ask that you'd share that with your networks as well. And then sort of on a broader note, if we could go to the next slide, thank you, Jen. On December 3rd is the International Day of Persons with Disabilities, and there is a great landing page here at the UN that goes over internationally what other countries are doing and how you can actually help individuals with disabilities in other countries. Some pretty interesting metrics there as well, looking at aging and older adults, looking at what some other, again, what other countries are doing, but wanted to acknowledge that December 3rd is the International Day of Persons with Disabilities, and ask that you share that information. It is quite eye-opening and I think very powerful to look through that information. We can go to the next slide. So I know that was a very quick hit on all things non-ARPA. Obviously, there is a lot happening for us in the months of November and December with our joint budget committee hearing, the beginning of sort of the stirrings of the legislature after the election. And so we'll keep everyone informed as to what's happening with those things and what's going on with the department overall. With our legislative agenda, that will be updated here as we move closer to the end of the calendar year. But wanted to see if anyone else had any questions for the good of the order. Okay. We go to the next slide, please. Thank you, Jen. We'd kindly ask that you take a very quick survey. It is literally only 60 seconds. It is really helpful for us to put together these webinars, to structure them in a way that works for you all, to look at different topics that maybe people are interested in. So please, 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 if you can, take 60 seconds of your day and take that survey. We can go to the next slide, please, Jen. Next webinar is actually not until 2023. So we have the new webinar schedule up. We'd like you to provide feedback or suggestions for, again, any topics, anything that you'd like to see on those. But we do not have any webinars in December, both with the Joint Budget Committee, a lot of people out around the holidays, spending time with family before the end of the year. Please, stay safe out there, especially with RSV, COVID, the flu. We hope everyone has a happy, healthy, and safe holiday. And with that, we will see you in the new year. Thanks so much, everyone.